Good afternoon. I pray that this recording goes over well, and I'm sorry that I could not get it uploaded, but I'm going to re-record it and try to get it uploaded so you can refer back to it. Chapter 2, where it talks about theories and and therapies. Again, as in class, we looked at several theories and what they thought or how they view individuals. And I kind of talked about Sigmund Freud, and we didn't really go into a lot on Sigmund Freud. But as you can see here, this is basically uh, based on the psychoanalytic theory. Freud views the level of awareness, how a person, whether they're conscious, looking at their conscious mind, and then the preconscious and the unconscious. And so basically, I kind of hit on that. This is also, he broke it down by looking at the id, the ego, and the superego. So again, that's that psychoanalytic theory. However, at the end of the day, when we look at the theories, um, we look at different mechanisms and anxiety, uh, why a person feel the way that they feel, or however, how they operate on conscious level, on their unconscious mind. Sometimes they may deny, falsify, or distort reality to make it less threatening. Say, for instance, they look at a situation, okay, there's not, it's just something minor. They look at it as a defense mechanism to before they, so again, it's a form of denial, how they can cope. They ward off anxiety by preventing conscious awareness of threatening feelings as well. So again, it's going back to the individual. And then Freud looks at the psychosexual stages of development. And again, I didn't really hit a lot on that. There was an audience course that you can look at. Also, based on the psychodynamic theory, we kind of look at also it focuses on different models, more on hearing now. There are several tools that can be used for the psychoanalytic theory of therapy. Just hit that little thing at the bottom. Hit that in place. Thank you, dear. Thank you. Again, I had to close my door. So again, like I said, the psychodynamic therapy, they use several tools. Um, And again, the therapist, what they do, they go back and forth between the therapist and the patient. Again, they want to have a clear understanding of why a client feels the way in which they feel. What is some understanding of the difficulty, what's going on in that client's life. Again, so basically, this is just a tool that could also be used. And we kind of read the case study in class, so I'll go back and kind of look at it again. This client is admitted after being picked up by the police. After she became stabilized, she spent the rest of the night on suicidal watch because going back to why was this client driving under the influence? Again, it could be something going on in her life, could be anxiety or depression or things like that. So, what led to the suicidal? So in the morning, she was admitted for like 5 days. She was admitted after she got out of jail. She went again to rehabilitation, and then she had a 3 day. She was admitted for 3 to 5 days for evaluation. That the police didn't press any charges against her for disturbing the peace because she has promised to get help. So again, until a person identifies that they have a problem and they seek help, there's nothing you can do about it unless there's a threat to the client or the environment. Then again, therefore, we talked about voluntary and involuntary admission to facilities, and the clients or they can be admitted voluntarily, involuntarily. Interpersonal therapy again is a balance, the purpose of behavior to get needs met through interpersonal interaction and to reduce levels of or avoid anxiety. So we look at the definition of anxiety, and I'm not going to read those verbatim, but it's a painful feeling or emotion. The client could feel insecure or could be due to um, some needs that have not been met, again, could cause the client to be anxious. Security operation, these are measures that emphasize uh, the individual to help them to look at reducing their anxiety levels and make sure that they feel secure. Self-esteem, all the security operation of individuals used to defense against anxiety, ensure self-esteem. Again, a client, they look at, what causes me to, have a low self-esteem. could, again, we look at different issues, what could cause that. There are several things that could cause a client to have a low self-esteem. Could be that they have failed, in life, or lost a job, or lost a friend, or whatever the case may be. There are different variables there. So interpersonal therapy is most effective in treating the grief and loss, also interpersonal disrupts, and also role transition, meaning that if somebody trying to transition from one area to another area, it could be um, interpersonal therapy would also be very beneficial. The next slide is a question, and I kind of like we had a discussion last week, and I hope I didn't confuse the client, but the students, I'm sorry, you guys. So I want to go back and look at this as you began working with her, the client that was picked up by the police. You notice that she has uncanny resemblance to your younger sister. So as a child, the sister lied and criticized you constantly, then screamed and cried to others if you challenged her. You realize that you are responding negatively to this patient. So again, why would the nurse be responding negative to this patient? So what's going on here? So the answer is countertransference. So countertransference is where it's unconscious feeling of the healthcare provider has toward the patient. So counter meaning that I kind of use an example of me losing a child, and so in an accident. So when I worked in the ER, when I saw that child came in and that was traumatized, so again I had some feelings toward that, not the child per se, but I kind of reflected back to my daughter. So again, countertransference when the worker, when um, you have those unconscious feelings about the patient. Then transference, on the other hand, is when the patient has those unconscious feelings about the nurse or the healthcare worker. When the patient say, "You reminds me of my mother or my father," or whatever the case may be. So counter is when the nurse or the healthcare provider have those feelings toward the patient. Then transference is when the patient have those feelings, unconscious feelings toward the healthcare provider. Okay, so this client reveals that she began drinking heavily over the last couple of weeks when her boyfriend tried to break up with her. During her stay, she received medication for depression and being having session of interpersonal therapy. So again, going back to what triggered her, what caused her to go out there and drink, break up with a boyfriend. So we kind of see what, like I said, what's the root of the problem. So she started having some interpersonal therapy. So again, nurses, the healthcare provider, we need to realize the importance of maintaining self-awareness and seeking supervisor guidance as the therapy relationship progresses. So again, we got to make sure when we're doing the therapy, it's in a constructive manner. Pavlov's, on the other hand, is another theorist that when he looks at the nurse as being both the participant and the observer. So self-awareness helps keeps focus on the patient. So again, and then we talk about Sullivan theory of anxiety toward nursing practice, and then so again, we try to do everything we can to lower the patient's anxiety and improve their ability to think and function. That's our goal. Then we have behavior therapy. Pavlov's is a good example of behavior therapies. And then Watson again, and then you have Skinner's. Also, this Skinner was a method of learning that toward reward and punishment for voluntary behavior. So if somebody did something good, then they got rewarded, and if they did something bad, they got punished. So again, behavioral responses are elicited through positive and negative reinforcement. What causes that behavior to occur? So we need to look at those things that cause it to occur and try to redirect those behaviors into positive responses. Also, sorry, I skipped over one mistake, and ultimately it talks about modeling, operational condition, exposure therapy. Modeling is basically where again, think about you being served as a role model. So the therapist provided a role model for the client, looking at their behavior. So the patient begin to learn what are their by imitating that therapist, and then operant conditioning. Again, use it to help to use for positive reinforcement to increase those desired behavior. We're trying to get the client to change their behaviors. Okay, so exposure therapy is what people use for people who experience anxiety due to fear, phobias, traumatic memories. In exposure therapy, patients are encouraged to face their fears and then again emotionally possess them in a safe environment. Again, okay, sometimes I'm gonna use the elevator for an example. So we try to get clients to ride the elevator. Now we don't force them to do that. So we want them to face their fears and then look at things they can do to calm down while they're on the elevator. Aversion theory, again, this is where they look at looking at targeted behaviors, which negative stimuli in order to extinguish undesirable behavior. Then you have biofeedback. This is where it's used for controlling the body's physiological responses to stress and anxiety. Meaning that physiologically, what can we do when the client get anxious to make sure that the heart rate doesn't go up and the blood pressure doesn't go up? So that's kind of like behavior feedback there. Then you have cognitive theory and therapies. Basically, cognitive, we look at everybody don't see things the same. So thoughts come from feelings and action. Thoughts about the world and places is based on our own unique perspective. Again, how a client perceives something is not going to be the way you perceive it. So we never try to change a client's perception. So again, because although it may not be or may not be based on reality, we try to, don't, because you believe in what you believe in. So those if those perceptions are not true, then we try to work the clients through dealing with those perceptions, trying to get them to, back to realities, for so to speak. And then with cognitive therapy also, we again with this therapy, based on the theory, we are trying to eradicate those irrational beliefs. Okay, and then try to get the client to see that those beliefs are not accurate. Okay, they may say there's some bugs crawling up the wall, so we try to reorient those clients, get them to talk about what they actually see, and try to get them to look at it from a different perspective. That those are not bugs. So you don't say, well, those are not bugs on the wall. You try to talk to them and just try to visualize, try to imagine or think about what they are saying, and then try to get them back to reality. And then you have cognitive behavior therapy. Again, it helps us to identify and treat those distorted beliefs and change the way of thinking. We're trying to help the client to change the way they think, which also will help reduce anxiety. You see, and then we have trauma focused cognitive behavior therapy. Um, this is a newer model here. Usually, you see this in clients that have been sexual abused. They've been traumatized as children. Again, so with this therapy, cognitive therapy, you want to try to get the caregivers in, the families in. It also helps the children and adolescents to identify feelings of how to manage those behaviors. So this is something that's trauma related. So we look at those, and a lot of time I was telling students also that sometimes it takes years for a person to talk about their abuse as a child. They don't want to talk about it. And so sometimes they get to the point where when they can cope with it, that's basically when they'll talk about it. And then we have the dialectical behavior theory also, which looks at strategies to help that patient and the therapist to give up extreme position. Also, individuals kind of they looking at those behaviors like how can we change your emotion? Sometimes any little thing can cause a person to explode. So what can we do to help deal to keep the clients from and then also it helps with um, emotional relations or regulation, interpersonal effectiveness also. And again, so that's basic cognitive, looking at what of the mind, what can we do to help a person change. So the implications for nurses, we need to begin to interplay, looking at the events, looking at those clients of negative thinking, and then the negative responses. So we're going to help those clients to identify what triggers something, what's a negative thought that you're having, how can we help you to look at it from a positive perspective? Then again, we have the theories of human motivation. This is basically it helps include it's a search that the psychology must be beyond experience of hate, pain, misery, guilt, conflict, and also human beings are active participants. We know that in life. Everybody wants to strive to reach their highest potential where they can be self-sufficient, self-actualization. And this kind of goes back to model Maslow's hierarchy of needs. At the very top of that pyramid, it talks about self-actualization. Everybody wants to reach their highest potential. Whenever your lower needs are not met, say if you go down to the bottom of the pyramid, say if safety is not met, it's going to meeting the needs of the client from a safety perspective. They don't have food, air, water, then they cannot reach their highest potential. That's self-actualization, which is the highest one on Maslow's pyramid. Also, as we talk about Maslow's, human beings are active participants in life, striving for self-actualization. Like I said, they want to reach that highest level. And again, like I said, when lower needs are not met, higher needs are going to be are able to. When lower needs are met, then a client they can move up the pyramid so they can reach their highest potential. So as we talk about Maslow's again, we have to meet their physiological need. For an example, if a client say they have an anxiety level, heart rate 120, blood pressure 180 over 100, we need to meet the physiological needs because they're going to die if we don't. Dysrhythmia, they will die. So they cannot reach their highest potential. So we need to look at the physiological needs, safety. Everybody want to be belong and love. They want to be loved. They need to have a need to be loved. Esteem needs, and again, like I said, self-actualization. So as you look at that, the physical needs, safety, you go down it goes up the pyramid like that. So implications for nurses, we need to emphasize on potential and the patient's strength. Uh, Looking at prioritizing those needs, what is important for the nurse, what is important for the client. Uh, Also, as we look, there's another model called the biological model, focus on neurological, chemical, biological, and genetic. So basically, what it's saying that a client may have a mental disease or mental illness. It could be neurological in nature, something going on in the brain. Could be chemically, could be basically chemical imbalance. Your serotonin, your norepinephrine could be an imbalance there, and then of course genetic. Again, it could be genetically, and then biological. We're looking at it could be drug induced. So these are some more biological models. Again, the environment, the culture. That's why we look at cultural. We have to respect the culture of clients because their culture can also impact their development as well. Focus on the quality of therapeutic relationship. Looking at the client's perspective, like I said, communicating. We got to communicate effectively to facilitate recovery. We got to understand. We got to teach the client. We got to communicate in an effort to meet the needs of the client. So communication is very important. Pharmacotherapy, this will be use medication to treat illness. So a client may be on medication in conjunction with therapy. So that's not uncommon. Usually we try to do the therapy first, but sometimes it doesn't work, so we have to go to medication as well. Also, some brain stimulation therapy, the ECG, the transcranial stimulation um, therapy, also your vagus nerve stimulation, deep brain. We're going to get into that more deep when we talk about different disorders and what is used for those specific disorders. But these are just some of the brain, the biological therapy that we could use for these clients. Also, implications for nurses, their physical needs, as you can see here. We're going to go back to that blood pressure, heart rate, respiratory rate. So the physical needs, the physical care and psychiatric nurses are part of a holistic approach. Again, you got to meet the needs. You got to treat those physical needs as well as the psychosocial. And again, you look at prioritization. And like I said, somebody can't breathe. They have a diagnosis of schizophrenia. Our priority is physiological, not psychological. So again, we're looking at focus on the quality of the therapeutic relationship, understanding the client perspective. I can't say that enough. Communicating in a way that their client can understand. Um, so like I said, in order to be effective and be receptive to your teaching, they got to understand. And again, this is Erickson's 8 stages of development. I'm not going to go through all of those, but as you can see here, trust versus mistrust, you see that a lot between the ages of 0 and 1 to 5. However, in meeting the needs of clients, they got to trust you. That could be at any stage. They got to trust you. So you have to develop that rapport, that trust relationship with the client.